Thank you so much for including me in this talk, and I apologise for the late start with some technical issues. Myself and my colleague, Dr. De Leon, radiation oncologist, would like to update you in terms of prostate cancer, some of the new developments, diagnosis and treatments which are available at the moment. And this will be a brief thumbnail through some of the clinical issues which we face at the moment. I'm going to dedicate my talk to the diagnosis and some of the treatments such as surgery and focal therapy, and Dr. De Leon's going to focus more on the radiation components and maybe some of the imaging components. So the first thing I think we need to really concentrate on is screening. And as general practitioners, obviously you face this every day. The whole reason why there's a controversy is that PSA may end up doing more harm than good. The harm, of course, is over-detection and over-treatment and the side effects of treatment. But the good is decreasing the death rate from prostate cancer and early curable detection. The way that we've addressed the harm is by increasing the amount of people who are monitored with low-grade cancers and being able to select the right people to treat with things such as MRIs, which we didn't have previously. So how do I screen? I think informed consent is absolutely essential. The PCFA guidelines help in that context. And we have to evaluate the PSA in context. A lot of people keep asking me about whether a digital rectal examination is still important. And I always say that a digital rectal examination is important for experienced general practitioners who are good at it. If you feel that this is something that you haven't done much of and you're inexperienced, then I think the strength of digital rectal examination is weaker than it was 20 years ago. When we do a test of a patient or invite them to be screened, we need to take their age into consideration. Obviously, we shouldn't be screening 80-year-old men routinely. We need to take their family history into consideration and urinary symptoms, and obviously whether they've got a very strong genetic family history such as the BRCA gene. These days, if the PSA is increased, increasingly now we use MRI as a secondary screening tool. Since the 1st of July 2018, MRI is now rebated if the PSA is elevated and is greater than 3 in the age group below 70. It does have to, however, be ordered by a specialist. If the PSA is even greater than 5 once, then it's also rebated. And it'd be worthwhile just checking the item numbers there because this saves patients about $600. The biopsy of a patient really depends on many factors. Obviously, it depends on the PSA. If the PSA is elevated and the person has a family history, it depends on the MRI findings. For example, if the MRI is normal and the PSA is only mildly elevated, these days we probably would not biopsy. It depends on digital examination. If there is an abnormality on DRE, we generally do tend to biopsy. And it depends on patient anxiety because patients who are anxious should be treated probably more carefully than people who aren't anxious in terms of eliminating their concerns. As far as informed consent goes, and I should bring that up now, it's important to make people understand that PSA testing, particularly with MRI as a secondary screening tool, does tend to pick the right cancers to treat. And I think the reassurance these days can be to patients that if they do have a low-grade tumour, it does not mean treatment, it just means monitoring. And so this reassurance that every person with any form of tumour gets treatment is no longer the case. On the other hand, we must emphasise that we're still not perfect at picking the right treatment, the right cancers to treat at this stage, and it does require quite a lengthy discussion about the person's life expectancy and the significance of the tumour. So when we do informed consent, I think it is important to realise there are still harms, but the benefits now are much stronger since active surveillance and MRIs come into the picture. Biopsies have improved markedly, and with the transperineal biopsy technique, we can now pretty well avoid the risk of infection with the old transrectal route. And as well as that, with MRIs being able to target these abnormalities, we can find more accurately, and we don't have those people like the old days, which ended up having 4 or 5 biopsies to find a cancer. There are definitely genetic risk factors, and I think the take-home message here is if you have a strong family history of prostate cancer, you can, and there's only one member, then you double the chance of cancer, but if you've got 2 close members, you 5-fold the incidence of prostate cancer. So it's very important to take that history. The history is much more significant if the family history is in a person under the age of 55. So, how do you test and how do you use the PSA wisely? Well, I mentioned informed consent, but it's really important to avoid the confounders of an elevated PSA, such as recent sexual activity, extreme bike riding, recent prostatitis. All of these things can put the PSA up, and it is important to avoid those things for about 2 to 3 days before a PSA reading. Some people take Proscar or finasteride at low dose for hair loss, and that will halve your PSA level, and it's important also to realise that. And finally, when you do the PSA, I think sometimes an isolated PSA is not the answer, but the rate of change of PSA over time, and that is called PSA velocity. And PSA velocity can be measured by noting the change of PSA per year. And if it goes up by more than 0.75 per calendar year, it's more significant. As well as that, the free to total PSA ratio can help you differentiate a benign cause of an elevated PSA and a malignant one. A malignant one tends to have a lower free to total PSA ratio. And so if you've got that grey zone PSA about 3 or 4 in a slightly enlarged prostate, the free to total PSA can be the differentiator between going to do an MRI or doing a biopsy. A little bit more about the MRI. It now is the new gold standard in prostate cancer imaging, tending to use a 3T machine, and we use a PIRADS reporting system. A multi-parametric MRI simply means that you do a picture called a T2 image, you look at water movement called diffusion-weighted imaging, and you look at perfusion called DCE. And all 3 can help you decide whether there is a significant cancer there. The reporting should be really fairly simple. A PIRAD 1 or 2 is basically a clear scan and gives you a less than 7% chance of cancer. A PIRAD 3 gives you a 20% chance of cancer, and a PIRAD 4 and 5 gives you an 85% chance of cancer. This is just to explain to you how the MRI works. Prostates have lots of glands, and if the cells are not forming glands, as in high-grade cancers, shown here on the right side of the screen, then the less water movement is reflected as a black area in a diffusion-weighted imaging. And this decreased water movement has been the secret of detecting early cancer of the prostate. So one of the big questions that keeps coming up is, if the MRI is clear, that is, it's a PIRADS 1 or 2, can we avoid a biopsy? The answer is, yes, you can, but other things should be taken into consideration. If it is a PIRADS 1 or 2, only between 4 and 7% of people have cancer of the prostate, depending on which study you believe. Obviously, there are other factors. For example, if you had a young man with a strong family history and a low free to total PSA ratio, you may still proceed with a biopsy even with a clear MRI because they're not perfect. We actually developed a nomogram to put all these other factors in to try and get a percentage chance of cancer based on all the factors, such as their age, their family history, the PIRAD score, and the volume of the prostate. But this is not in common use at the level of the general practitioner. So MRI will have an increasing role in aiding PSA screening, and future trials and improved standardization will definitely improve its role. I now always do an MRI before a biopsy, and so should everybody. We're also evaluating the role of what's called PSMA PET scanning at the moment as well. And PSMA PET scanning is a new PET scan which only detects really prostate cancer in the body. We're currently evaluating this as a screening tool to improve the accuracy of MRI. These results should be available within the next year, and at the moment it looks like it helps improve the accuracy, and maybe we can decrease the chance of missing cancer to even less than 3%. It's also possible in the future that a positive PSMA PET scan and positive MRI may be so conclusive that a biopsy becomes unnecessary. Transperineal biopsy, which I mentioned before, is much safer than transrectal biopsy. It's better for many, many reasons, not the least of which is it has less infection, and it's better at targeting cancers, particularly if we're targeting things on an MRI. The fusion technique, where you fuse the ultrasound to the MRI, is common practice now and should be something that's used particularly where there's a small lesion which is difficult to target accurately. If I could leave the screening now and move on to treatments. The treatment of prostate cancer isn't a simple thing anymore. And I think it's really important to explain to our patients that the diagnosis of cancer and treatment of cancer are two totally separate issues. In the treatment of cancer of the prostate, there are many factors that need to be taken into consideration. The options are monitoring the cancer, such as low-grade cancers, surgery, low-dose rate brachytherapy, high-dose rate brachytherapy, all the forms of radiotherapy that my colleague Dr. De Leon will go through. And even more recently, I've been developing some focal therapy, a bit like lumpectomy with breast cancer. So there are many factors to consider at the time when you're deciding which treatment to use. Obviously, the tumour itself, the Gleason score, or these days, the ISUP grade, which goes from 1 to 5. The prostate factors, have you got a big prostate? Have you got urinary symptoms? The local factors, are there things in the pelvis which might obviate surgery or radiotherapy, such as ulcerative colitis with radiotherapy, or fractured pelvis with surgery? The patient factors, what's their biggest fear? Is it incontinence? Is it bowel damage? Is it erectile dysfunction? And then obviously the institutional factors, what are you good at? What's good at that institution? Hopefully everything. The treatments have to be individualized. It's not enough these days just to say, you've got a cancer, let's rip it out. it really needs a discussion, usually with the partner and the patient. It often needs a multidisciplinary team approach where a urologist, a radiation oncologist, even sometimes a medical oncologist, a clinical trials expert discusses all the options, and sometimes even a sexual health physician to help individualize the treatment. This is not something that should be jumped at quickly, and second opinions are to be encouraged. Complicating this is the fact that some of the studies show that active surveillance, radical prostatectomy and radiotherapy have a similar death rate even after a long time. But this is particularly so in low-grade Gleason 6 cancers or level 1 cancers. And so these days, with low-grade cancers, active surveillance has become a much more common option, and in fact is the preferred option. I think it's important to realize when people are making a decision that each treatment carries a very different type of side effect profile. For example, there is a higher incidence of incontinence with surgery, and there's a higher incidence of irritative urinary symptoms with radiation treatments, and the bowel bother level is slightly higher with radiation than surgery. But again, Dr. De Leon will go into that more. Sexual function, for example, has a lower incidence in brachytherapy, an external beam, than surgery in population studies, but not so much in centers of excellence. So when comparing surgery versus radiotherapy, the potential benefits of surgery is that it will improve urinary symptoms. If it fails, then salvage radiotherapy is still a possibility. We're not dealing ever with radio-recurrent disease. There's no second malignancy, which can occur in a small number of cases after radiation. And there's more pathological information and less long-term side effects from the urinary tract. But on the other hand, radiotherapy is less invasive, there's less incontinence, it's better for certain positions of tumours, and it's easier in some patients, particularly those patients who are obese, fractured pelvis, adhesions, or unfit. So it's a discussion, and often a multidisciplinary discussion. Active surveillance. The ideal patient for active surveillance is somebody with a Gleason 6 tumour, but even some Gleason 3+4 tumours, the so-called level 2 tumours now, are being considered for active surveillance in carefully selected patients. The reason why is because we've learned that some of these tumours are relatively indolent and non-life-threatening, and these days we should never scare the patient with the cancer word. In fact, what we should be doing is saying that this could have been overcalled and maybe we shouldn't even be calling it a cancer in the first place. However, we must be extremely careful we haven't undersampled or underassessed the prostate, and by doing a good quality MRI and biopsy, that is generally these days not the case. If we do go into active surveillance, it does require monitoring with regular PSAs, imaging, and the occasional biopsy, often as few as every 4 to 5 years. Even genetic markers are having their role in this area, where sometimes you can analyze the tissue to see if it's a good or a bad cancer. Why should this active surveillance be so popular? Well, what we've learned is that Gleason 6 tumours, even in the 50 to 59-year-old age group, are incredibly common. 44% of the normal population harbour these. So clearly, this is not the 3% of people who are going to die of prostate cancer. This is a very prevalent and relatively harmless condition. The other thing that supports the fact that active surveillance is a good thing is the long-term 20-year follow-up of some of the series, which shows that the death rate from Gleason 6 cancers, even after 20 years, is incredibly low, almost a 0% incidence of death rate, with no treatment. And this is a typical example of a person who's been on active surveillance for a time. And here you can see the PSA fluctuating over time. And they went on to DuoDart or Avidart. PSA came down, but then the PSA went up on the Avidart, and then an MRI was done. And here you can see that there's a small lesion in a big prostate, and that turned out to be a Gleason 9 cancer. So you can pick up the high-grade cancers on active surveillance, and about 10 to 20% of people on active surveillance over about a 10-year period will eventually have treatment. The question to ask, of course, is whether that delay in any way compromised the patient, and the firm answer to that is no. I might skip over the genomics aid because I think that this is a more important slide. There are some new tests called Oncotype DX, Decipher, and Prolaris, which can be looked at the tissue to try and see whether it's a good cancer or a bad cancer. Now, there's no question that a low-volume Gleason 6 cancer needs active surveillance. There's no question that a high-volume Gleason 3+4 cancer needs treatment. But there's this grey zone in the middle, and this grey zone in the middle here is the high-volume Gleason 6s or the people with an abnormal MRI, and those people are people who might benefit from having a genomics test to see if they fall into the ones that we need to treat, such as the Gleason 3+4, or the ones we don't need to treat, like the less extensive Gleason 6. At this stage, it's not routinely used in Australia, but it is routinely used in the States. As I mentioned, there's 3 available markers, but these are expensive in Australia, and again, in the States, they're covered by the health insurance. When we have a person with a Gleason 7, a good 7 tumour, and he's wishing to avoid treatment if possible, particularly if he's, say, in his 70s, and the risk is very low to him, then I think it's in this group that you may offer active surveillance to them, but you need to monitor them very carefully. With surgery, if I could just briefly go into surgery, the aim of surgery, of course, is cure, continence, and potency, no complications, and a rapid recovery. One of the important things to understand here is that the complete removal of the prostate is more dependent on the skill and experience of the surgeon or team rather than which technology is used. One of the questions that patients often ask me is, does surgery really work? Well, the New England Journal of Medicine, one of the top journals in the world, after an 18-year follow-up on what's called the Bill Axelson trial, showed that surgery compared to watchful waiting doubled the, surgery halved the death rate from prostate cancer if you compared it to doing nothing, and that was excluding low-risk patients. It has been, however, shown that it's remarkably difficult to cure people with high-risk cancers, but this trial didn't look at people having what's called multimodal therapy, where they combine surgery and radiotherapy or combine various forms of radiotherapy treatment. So does surgery work? Yes, it does, but in high-grade cancers often should be used as part of a combination of treatments. A lot of people also ask about, should it be the robot or open? A lot of these questions are now resolved because with experienced robotic surgeons, not only do you have the benefit of the more rapid recovery, there's now early emerging evidence that there's lower positive surgical margins, lower complications, and lower chance of post-op radiotherapy than the open results. But with time, most of the young urologists are trained in robotic surgery, and so this is simply replacing open surgery. I've done myself over 2,000 robotic procedures, and from my experience, not only is there a quicker recovery, less blood loss and less complications, but there's better cancer control in my hands, The hard cases are easier, such as the obese or underslung prostates. I have less back pain. It's much easier to teach, and the potential for improvement in the future is much greater in terms of adding things such as imaging overlying the prostate while you're doing the operation. However, there is a massive learning curve, and in my case that was about 500 cases, and even in fellowship trained urologists the learning curve is probably about 100 cases. And until you're over that learning curve, the results could even be worse than, it could be substantially worse than anticipated. So I think that's important, that experience is acknowledged. The concept of nerve sparing does not equal potency preserving. Nerve sparing means you're maximizing the chance of potency recovery. And the dilemma here is that the tumor often is very close to the nerves, and so that fine balance between clearing the tumor and preserving the nerves is obviously a very, very important concept. And increasingly, nerve sparing is being adopted even in higher grade cancers. It's not a matter of all or nothing with nerves. Sometimes you can preserve some of the nerves and get a 75% chance of erectile recovery, or even 50% of the nerve with a 50% chance. So it's not that you do a non-nerve sparing procedure or a nerve sparing. It all depends on exactly where the cancer is. So I like to make the analogy of a report card, that the surgeon's report card should be, what's your chance of getting a clear margin if the cancer is contained? The chance of getting a cleared margin should be extremely high, well over 95%. What's your positive surgical margin rate? How many people are you treating with Gleason 6 cancers where they should be on active surveillance? What's your major complication rate? What's your continence rate? What's your potency rate? And these days, cancer registries keep all this information, and hopefully that will encourage surgeons to improve their own report card. I don't know if the videos come up very well, but this is just an interesting video of one of the new developments which is going to come up very shortly. This is called the single port robot, where one hole is put in the patient and all the instruments literally come out of the one hole, the telescope and all the working elements. And this will be first trial that's in Vincent's probably in about 12 months time after the TGA approves it. And as you can see, with one hole, and to be able to do all this in one through one hole, it will have less of an impact. It has particularly good appeal in the areas of ENT where it can go through the throat. And just the last thing I'd like to touch on is focal therapy, and I'll be as brief as possible. Focal therapy is where you find a cancer of the prostate in a very localized area, and you feel that treating it locally might be an option instead of removing the prostate or irradiating the prostate. Obviously, this is in a very select group of people, generally in an intermediate grade of patient, and it should still be regarded as an emerging treatment, not established. I started this program about 7 years ago, and I've done about 350 cases now, and I'll share the results of that. Again, highly selective. A person like this where you've got a little cancer found on an MRI, maybe a 72-year-old gentleman. We know that there's always a little bit more cancer than you think there is around that. But so when you do focal therapy, you always have to have a bit of a safety margin as well. So in the past, low-risk cancer got active surveillance, and high-risk cancer got whole gland therapy. It could be in the future that the intermediate cancers get focal therapy if they're localized to one area. This is only speculative at this stage. So why do we need focal therapy? Well, we know that a lot of people with Gleason 7 tumors are overtreated. It's got less side effects than whole gland therapy. 20% of cancers, I believe, are unifocal, not all through the prostate. And we're better at picking the right person for focal therapy with thorough MRIs and template biopsies. The question is, can we accurately select these patients? And I think with a combination of MRI and transperineal biopsy, possibly also with PSMA PET scanning, I think we may be able to pick the right patients. But we shouldn't be picking high-grade cancers because at this stage, it's too early in its development. Again, I tend to pick people who are unsuitable or refuse whole gland therapy and people who only have Gleason 7 tumours and where there's new lesions on active surveillance, or certainly where the PSA is less than 15. My favourite energy source is irreversible electroporation, which is an electricity which is passed into the area to kill the cancer off. And the nice thing about that, it's a day procedure, and basically you treat the cancer, but it does require very careful follow-up. These are my results, recently published, 320 patients, and if I can focus you on the clearance of the cancer of the primary tumour based on biopsies, 96% clearance, and about a 12% chance of recurrence over about a 5-year period. And it can be redone. In terms of functional, pretty well all pad-free and about 10% potency problems, which tends to recover. So the side effects are less. It's not proven. It requires follow-up, and it's not for everybody. But it's something that should be considered in some slightly older people with Gleason 7 cancers. I'll pass that. And just before Dr. Leon takes over, it's important to understand that urinary incontinence problems, which could be caused by surgery, have a treatment with different forms of therapy. One therapy is a sling, another one is an artificial sphincter. Erectile dysfunction can be managed with vacuum devices, injections, and tablets. Self-injection therapy, you'd all be familiar with Cavaject. Vacuum devices are underutilized, and even penile prostheses. And the PSMA PET scan is making a major impact on the ability to stage these cancers. And it's already got a role in detecting disease after surgery, but it may have a role in detecting cancer even before, after a PSA. So rather than do anything more, I'll hand over to Dr. De Leon, and if I could just summarize the future, I think the future will be screening with a much more sophisticated technique of PSA, MRI, and PSMA, better imaging in the future with PET and MRI, genomic profiling, image-guided surgery, targeted radiotherapy, possibly super anti-androgens and immune therapy and focal therapy. So I'd like to hand over now to Dr. De Leon. So thank you for your time.
Thank you, Professor Stricker. We've just got one quick question before we hand over. What is the role of scandium-47 in the diagnosis and treatment of prostate cancer?
Did you say scandium?
Yep.
So the question is, what's the role of scandium in the diagnosis of prostate cancer? There's a lot of investigations with many different forms of early diagnosis with messenger RNA, scandium, but at this stage they haven't been tested in large population cohorts, and so until they're really tested against large population cohorts and shown in a randomized trial to pick up the significant cancers, I think we shouldn't move away from what we're doing.
Okay, and then just one last question. How to manage patient if free to total PSA ratio falls between 10 and 25%?
So the question is free to total PSA, how do we use it? The extremes help, but the grey zone doesn't. So if it's less than 10%, the free to total ratio, that really pushes me to want to investigate that man. However, there is one area that causes a low free to total ratio, and that's in a person recovering from prostatitis. So if they're not recovering from prostatitis and the free to total ratio is less than 10%, that pushes me to a biopsy irrespective of the MRI findings. If the PSA free to total ratio is greater than 25%, that pushes me to be rather non-invasive. And between the areas of 10 and 25%, it doesn't really help me. I then tend to rely much more on the PSA density and the MRI findings.
Okay, and just another question, are all MRIs equal if we choose to perform one?
The question is, are all MRIs equal? No. There's a massive difference between the quality of MRI reports, and this was recently published in the radiology journals. So you need to have a person with a good reputation who does a lot of MRIs, and usually you have to do your own research as to who the experts are in this field. A poor MRI with a poor report is not a good option, and unfortunately at this stage we don't have credentialing to make sure that every radiologist is giving a good report.
Great, thank you, Professor. These are all the questions we have at the moment. We will hand over to Dr. De Leon, and if you do have any questions, please type it into the questions tab and we can revisit them. So thank you.
Thank you.
Getting my screen ready. All right, I'll get started then. Thank you, Professor Strickland, for that really excellent overview and summary of management of prostate cancer. And also thank you to the organisers of this for allowing me to talk about treatment of prostate cancer with a focus on radiotherapy treatment in these cases. With regards to radiotherapy, there are a lot of terms which are thrown around, and I hope to essentially cover these and more so go over what your patients will go through if they decide or are treated with one of these modalities. They include brachytherapy, stated those are seeds, or low dose rate brachytherapy or high dose rate brachytherapy, external beam radiotherapy, newer technologies which have been brought to St. Vincent Genesis Care's MRI Linac, and also time permitting to talk about post-prostatectomy radiotherapy. Pacifica touched on this earlier, but I can't stress enough the importance of multidisciplinary teams. We're quite fortunate in our multidisciplinary team chaired by Professor because not only do we have urologists, radiation oncologists, medical oncologists, we have leading nuclear medicine physicians, radiologists, pathologists in there. And it's important that patients are seeing specialists who are members of an established multidisciplinary team because of the complexity in determining what's the best course of treatment for patients with prostate cancer. And it always ensures that there's best practice being maintained for your patient. And the reason that's important is not all prostate cancer is the same. We commonly use things such as the NCCN guidelines as to stratify prostate cancer into low, intermediate, and high. And in the last couple of years, we've even broken those down to very low and low, and high and very high. And the reason that's important is, and I'm purely just putting here the radiotherapy options for treatment. So I stress again that active surveillance, as outlined by Professor Stricker, and surgery all have their roles in treating. But purely looking at the radiotherapy options, you can see that there are multiple which can be used in certain circumstances, depending on the patient's risk category. I put this up to essentially highlight brachytherapy. So brachytherapy, the two main types we have are commonly known as seeds or high dose rate brachytherapy. Seeds is essentially the placement of permanent radioactive seeds into the prostate. These will essentially give off the radiotherapy direct into the prostate and remain in the patient permanently. Obviously, they do not emit forever, meaning that the patient is not radioactive their whole life. High dose rate brachytherapy involves the placement of catheters into the prostate, and then these are connected to wires which deliver a radioactive source to the prostate temporarily, and these are taken out, and these catheters are taken out. And the reason these are important and what we know is that it allows high doses of radiation to be delivered to the prostate. And what we can see here in the graphs on the right, the graph at the top left of your screen is looking at low risk cancers. The graph in the middle is looking at intermediate risk prostate cancers, and the graph at the bottom is looking at high risk prostate cancers. And the only thing I draw your attention to, first of all, in that top left corner, is brachytherapy seemed to imply it had a better PSA-free outcome, and that was maintained in all of these slides. Anything which used brachytherapy had a better outcome than just traditional external beam radiotherapy. With regards to the low dose rate brachytherapy, this is a procedure done with the urologist, such as Professor Stricker. What's involved is the first point of call for your patient would be a volume study, which involves an ultrasound study of the prostate. And then this is taken away, and over the next 4 weeks, it is determined where is the optimal place to place these radioactive seeds, so as to ensure cancer is being treated, but also to ensure the amount of radiation going to the normal organs around it is minimal. Subsequently, once a plan is in place, again, with the urologist, the patient is anesthetized, and then that map which was created in the planning is used to guide the placement of these seeds, which are done directly into the prostate. They recover from their treatment, they recover from the anesthetic, they undergo a repeat CT scan, and then essentially they've received that part of their treatment. Now, seeds brachytherapy can sometimes be used in combination with external beam radiotherapy, and it's commonly in the order of 25 treatments, although there is some evidence showing the potential to go down to 12 treatments. And this would start approximately 8 weeks after they've had their brachytherapy seeds placement. High dose rate brachytherapy is slightly different in that they do not have a volume study or a planning study per se. They undergo placement of these in the bottom, sort of the middle of your screen. They undergo insertion of these catheters through the perineum. Again, these are done with urology colleagues in predefined areas in the prostate. These remain in there. They recover from the anesthetic. They subsequently undergo a CT scan that same day. The needles are adjusted to ensure they're in the exact correct position. A plan is created to determine where the radioactive source needs to go into each of these catheters because they'll be in different parts of the prostate. And then the treatment is delivered, and how it's delivered is those catheters are attached to this machine that you can see on the right of your screen. And the radioactive seed goes into each one of those wires to deliver the treatment. The patient is awake during that. The patient is awake essentially once they recover from an anesthetic. So they have one procedure to put the catheters in through the perineum, and then their treatments are done 6 hours apart. Again, this is commonly combined with external beam radiotherapy, be it 25 treatments or 12, and this would start at least 10 days after the brachytherapy procedure. So we know that brachytherapy does have an improved outcome compared to traditional external beam radiotherapy, and the feeling is because of the ability to deliver higher doses of radiation to the prostate. However, with any treatments, it's also important to understand what the potential side effects are. And this is an Australian paper done through Melbourne, and it looked at HDR brachytherapy versus radiotherapy alone, and there was no doubt that there was an improvement in prostate cancer outcome with the patients that had brachytherapy. However, there was quite a significant increase in the risk of urethral toxicity, and those toxicities involved either requiring catheterization, dilatation, or surgery. Obviously, brachytherapy, especially HDR brachytherapy, is I guess doctor dependent in terms of who are doing it and the skill in which they're doing it. Obviously, in quite skilled and qualified hands, as with Chris Vicker and the St. Vincent team, these rates are quite low. With regards to external beam radiotherapy, this was touched on again by Professor Stricker. This looked at, this is the only randomized trial actually comparing treatment with regards to radiotherapy surgery and active monitoring, and it mainly involved patients which were that intermediate risk group of patients, which would be those Gleason's 10 to 20 and Gleason score 7 or less. And the main take-home message there you can see in the graph, looking at the blue and the red line, is that radiotherapy and surgery seem to have the same outcome in prostate cancer-specific survival, all the way up to 8+ years, and also in terms of disease-free survival. Of interesting note was the patients that had active monitoring in terms of their prostate cancer-specific survival also had similar rates, but it's also important to know that a significant proportion of the patients who were randomized to active monitoring or surveillance ended up having some sort of active treatment within that time period. Looking at the potential side effects of treatment, and this is a follow-up paper from that same study, looking at patient-reported outcomes, and I think the main take-home here is, again, with radical prostatectomy in red, radiotherapy in orange. If we start looking at the urinary symptoms, there is slightly worse urinary symptoms initially after the radical prostatectomy, but there is also a worsening of urinary symptoms after radical radiotherapy, and these are all compared to patients that had nothing. But we can see as time goes on, they completely recover to equivalent. With regards to bowel symptoms, what we can see there is that with regards to radical prostatectomy, there is no change in their bowel symptoms. There is no worsening of it. There is an acute worsening following radiotherapy in these cohort of patients, but it does tend to improve close to baseline levels. And then regards to sexual bladder score or function, again, we see that regardless of what treatment modality, there is a slight worsening in sexual function. However, there is some recovery of that with the passage of time. With radiotherapy, I guess there is also the concept of, previously it used to take up to 8 weeks to deliver radiotherapy treatment, and they were daily visits. Granted, it took about half an hour of the patient's time from coming in the door to going out the door, but it was still 8 weeks of coming in. There's been a lot of interest, and I would hazard to say that it would probably have to be considered on the standard of care now to go to shorter treatments, especially in this intermediate risk patient group. So this was a study which was published a couple of years back, which looked at that standard 8 weeks of treatment versus 4. And the take home we found from that was that there was no difference in terms of prostate cancer outcome, and there was no difference in terms of toxicity. Now this study only reported up to 5 years, as yet they have yet to update that, but the graph seems to be showing that they would continue along the same line. However, the question then became, can you give even fewer treatments? And something which has been done in a lot of specialized centers now, including our centers here, is stereotactic radiotherapy. Essentially, stereotactic radiotherapy is the ability to deliver really high doses of radiotherapy to the prostate at each treatment. And this means that prostate cancers can be treated in 5 visits into the center. And the requirement of this is extreme accuracy. Accuracy in the technology that is used to deliver this treatment, but also in the accuracy and skill base of the doctors delivering this treatment. A systematic review and meta-analysis of about 6,000 patients treated on multiple trials. Again, a lot of these were just trials, centers experienced trials, but we can see that the biochemical control or the rates of prostate cancer control or cure was extremely high, all the way up to 8+ years using this technique. However, again, with any sort of treatment, the question always will come down to what are the potential toxicities with treatment. And again, that we can see here that there is a short-term worsening of urinary function and bowel function with extremely stereotactic radiotherapy. However, it does look to improve back to baseline. Sexual function does go down, and it seems to decline at a slow rate post-treatment. It is, though, a question, is this a true reflection of the treatment itself, or is it multifactorial in that a lot of the patients treated on these trials were a lot older? So I guess just summarizing that part of the talk in terms of the radiotherapy treatment options, we know that brachytherapy is excellent. It's excellent at increasing the dose of radiation to the prostate and can be commonly combined with external beam radiotherapy. And the studies have shown that there is an improved outcome. However, it is an invasive procedure, and the trials have shown that there is up to 10 times the risk of significant toxicity. Latest Australian data does show that the use of high dose rate brachytherapy in Australia is decreasing, and SEEDS brachytherapy is still maintaining at its current usage. With regards to external beam radiotherapy, so not invasive radiotherapy, quote unquote, there has been a strong move to doing this treatment in fewer visits, all the way down to potentially 5 visits. With modern techniques and modern equipment, the side effect profile, as you can see, is well tolerated and quite low. In the only randomized trial, again, this was only in low to mainly intermediate risk cancers. There was equivalence to surgery, but also we're being able to deliver a higher dose of radiation using this technique to the prostate, which is the basis of the benefit of brachytherapy. And also the ability to treat lymph nodes, which I won't go into too much detail, but in certain cancers, there is the requirement to treat the lymph nodes, and these can obviously be surgically or with radiotherapy. The next part I wanted to go over was just what is the standard radiotherapy process, and I think it's important as yourself being the primary carers for your patients, just an understanding of what is involved once they see and are consented to go ahead with some form of radiotherapy treatment.
Dr. DeLeon, before you go on, can I just get you to check the sound, maybe unplug the earphones because it's sounding a bit muffled. And okay. Professor Stricker, can you mute yourself because your sound is coming through as well?
I'll drop it.
Is that better? Can you hear me better now?
That sounds a bit better. Yeah, we'll just see how we go, and I'll let you know if there's any issues. Thank you.
Okay, thank you. So regards to treating with radiotherapy, there are a number of steps involved, especially in treatment of prostate cancer. And all I wanted to do was just to run through what these steps are involved. Again, so you know what your patients are going through when they go through radiotherapy. With regards to standard radiotherapy, and sorry, the picture here would be what we call a linear accelerator or a LINAC. It's the machine used to deliver radiotherapy treatment to the patients. So with the first step is the placement of fiducials. These are done by a urologist commonly, and what it involves transperineally the placement of 3 gold seeds into the prostate. The gold seeds are about the size of half a grain of rice, and the reason that is placed in is, as you can see on an X-ray, knowing where these gold seeds are into the prostate allows accuracy in terms of defining the prostate, as during treatment, and I'll go over this in the next part of the slides, we can't actually see the prostate when we treat them each day. The other thing which can be used for certain patients is something called hydrogel, also known as space OAR, or another company currently being used is Barrigel. This involves the placement of a gel, as its name implies, between the prostate and the rectum. And again, this is done commonly by urology colleagues. And what is done is, you can see in the diagram on the left here, this gel is inserted into the space between the rectal wall and the prostate. This gel commonly will stay, especially with space OAR or hydrogel, this gel stays in there for approximately 3 months. However, it's naturally degraded, and after 3 months, it actually is completely gone from the body. Barrigel, which is a newer gel which is being used, it stays in there for about a year, but again, it would disintegrate after a year. And the importance of this is about the ability to move the rectum away from the prostate. And the importance of that is knowing that there is that space there means that there's the ability to reduce the amount of radiation that the rectum is getting. After a patient would have the fiducials and or the hydrogel or spacer, they will undergo what will commonly be termed the simulation scan. And essentially, this is a CT scan of the patient done in the radiotherapy department. Patients would be asked to have a comfortable full bladder and an empty rectum. And an empty rectum would normally just imply that they've opened their bowels that morning. And a comfortable full bladder, different practices will use different instructions, but commonly would involve asking the patient to empty their bladder an hour before and to drink 400 or 500 bottle of water and hold that in their bladder. Also at this appointment, the patients will get those little tattoos, which you've probably seen on your patients. They're the size of a full stop on a piece of paper, and they commonly get 3 tattoos, one on each side of the hips and one anteriorly, just on the pelvic area. The next stage is the contouring and the planning aspect of their treatment. And essentially, this is what takes the longest part before they start. And what's involved in this case is that the radiation oncologist, the doctor themselves, would go through their scans, go through their other scans they've had done, go through their operative reports, go through their biopsy reports, and would use that to define the area that they're going to treat, essentially defining the prostate, and if they need to include anything else, such as seminal vesicles or the pelvic nodes. But also they would need to define the other organs which are critical that should not be getting significant radiation. The radiation oncologist will also then define how much radiation he wants each of those organs to get. And then after that, a radiotherapist, who is a trained individual in terms of works out how to ensure that the amount of radiation going to each of those organs is meeting the criteria which has been set by the radiation oncologist. This process is a back and forth process in terms of ensuring that the actual plan that they get is the best plan for that patient. And this process commonly can take between 1 to 2 weeks. So between having their simulation to starting their treatment can be between 1 to 2 weeks. With regards to treatment, what happens at treatment? So treatments can be anywhere between 15 to 45 minutes. And the longer the treatments are commonly for those treatments where we're using stereotactic approaches, because it requires more accuracy and it requires even longer to deliver the radiotherapy. Of those 15 to 45 minutes, majority of the actual time itself is spent setting up and ensuring that everything is checked against where it should be. Now, when I say checks, what we can see here, this is the quality of a scan which you can get on a standard linear accelerator. And what the team has done here is they've done this scan. Having had those fiducial seeds put in, they can accurately see where they should be, and they use that to define where the prostate should be in relation to those seeds, having done that previous scan at the beginning. What we can also see from this scan is that yellow is the bladder and the brown obviously is the rectum, and they were where the organs were at the very first scan that they had done and was used to create the plan. And again, they want to make sure that this is as close as possible, accepting it may not be perfect. Once all these checks are done and that everyone is 100% sure, happy that we're exactly in the right spot we want to do, the actual radiation beam is turned on. Now, the radiation beam, the best way to think of it is it's a strong X-ray pointed at the area, so nothing actually touches the patient throughout this whole procedure. And an arm will just rotate around the patient so that they're never completely enclosed and they're never covered up, and they can always see the whole room. And the amount of time that that's on delivering the X-rays to that area is in the order of about 5 to 10 minutes. Again, the longer amount of time is when we're doing a stereotactic approach and delivering a higher dose of radiation. And like I said, this process of treatment can occur up to 5 to 39 times. These visits are usually during weekdays and not weekends and not public holidays. However, with radiotherapy, there's always looking at advancing technology, and we've been quite fortunate here at St. Vincent's to have installed one of the, I guess, the biggest advances in radiation treatment for prostate cancer, and that is called the MRI LINAC. There was a paper outlining what this is done, authored by myself and Dr. Jameson, who is one of our physicist leads at Genesis Care. And essentially what the MRI LINAC does is it combines an MRI machine and a linear accelerator. And the ability that that offers us is it allows us to do what we call adaptive radiotherapy. And essentially that means we can ensure that the radiotherapy plans are accounting for any change in the patient's anatomy, because we know that organs will move day to day. We also know they'll move second to second. So in a sense, it means the cancer is getting the radiation, the normal organs are being spared the radiation. We can have more accuracy in ensuring that. This leads to precision. It also means that treatments can potentially be completely non-invasive. As I said, it is one of the new and most advanced technologies. So there's currently approximately 20, or I think 24 in the world, 2 in Australia, 1 in Sydney, here at St. Vincent's campus. We've been quite fortunate in bringing this across and working with post-treatment urology colleagues to really offer a complete urology service with regards to radiotherapy. With regards to the treatment process, it is slightly different, and I'll just step through each one. The first is that there is no need for fiducials. So those gold seeds I talked about half the size of grain of rice, are not needed to be inserted. And I'll explain why that is, again, in a few slides' time. We still do the same process in terms we do a contouring and planning. The difference, though, is that instead of using a CT to develop our plan, we're using MRIs obtained on a 1.5 Tesla machine. And as stated in Professor Stricker's talk, MRI is becoming so important now in diagnosing prostate cancer. Now we're using it to help us define the areas that we want to treat. And we can see the big difference in the quality of the image between a CT and MRI here. Sorry. With regards to treatment, the big difference is that with a patient's treatment, with a standard treatment, what commonly happens is, as I stated, they have a plan created at the very beginning, and every day we know that things aren't perfectly lined up, but we aim to make that plan fit that anatomy on that day. And the evidence has shown that this works. This is how we've got no evidence for radiotherapy in prostate cancer. However, what we're able to see here is when we compare the checked image, quote unquote, we get on a standard machine on the left to, in a sense, the image we're getting when we treat the patient on the MRI LINAC, we can see that it's vastly different. What happens when the patient is treated on the MRI LINAC is that the radiation oncologist, for the doctor, is present for their entire treatment each time they come in, and that I would, or colleagues would define again the exact area we want to treat, the areas we do not want to treat, and then a completely new plan is created so that we're accounting for any move which has happened day to day to ensure that the amount of radiation again to the cancer is what we want and to the normal organs is what we want. So in a sense, that 1 to 2 week process of planning we do that in 20 minutes with the patient on the bed. And the reason that's important is there has been quite a few studies, and one of the main ones published quite a while ago showed that if you weren't replanning your treatment every day because the technology at the time wasn't available, it meant that about a third of the treatments, if you could do them again, you would have to do them again because either the tumors weren't covered or the normal organs were getting too much radiation. Another important factor with the MRI linac is its ability for us to actually see what is happening while the patient is having treatment, while that beam is on. And what you can see here is an actual image taken from our machine of a patient. While the beam was on, this was running full time, so that if at any reason there was significant movement, we could stop our treatment and wait for things to settle or completely replan them because something had changed. I just wanted to go through a quick few cases, and I should be wrapping up soon. So this was a gentleman who had intermediate-risk prostate cancer. He had seen a urologist and his radiation oncologist, and for personal reasons, he did not want any interventional procedures done at all. So he was sent to us for consideration of MRI linac treatment because he did not even want the fiducial put in. The image we see on the right just highlights what I was speaking before. So this was actually an MRI done at one of his treatments, and the brown and the yellow was at what his bladder and bowel were at the very beginning. So we can see that there already is a change. And had we tried to treat that with that original plan, it would not be perfect. However, these are just sample images taken from each one of his treatments. And we can see that every time there was a change, we adapted for that and ensured that he was receiving precise and accurate treatment. And at the end of treatment, he had reported no urinary or bowel symptoms. Our second case was a gentleman who was a rural patient. Again, he had intermediate risk prostate cancer.
Professor Stricker, could we get you to mute your phone because we can hear you.
I just turned on the sound of the video. Okay, I'll turn it off.
So this was a patient who had intermediate risk prostate cancer. Again, he himself had chosen not for interventional procedures, and he wanted as quick a treatment as possible. So I should mention the first patient wasn't suitable for 5 treatments, and it was because of urinary function. This patient was suitable for 5 treatments. And again, every day that there was a change, we adapted for that and delivered the radiotherapy treatment. This was a case of a gentleman that had had previous focal therapy and had done it extremely well over a number of years. However, his PSA had started to go up a little bit, and imaging and workup had revealed the treated area. There was no evidence of cancer. However, there was new sites of cancer on the other side of the prostate. With regards to radiotherapy in this case, there's not a lot of published evidence of what to do. Mainly because as radiation oncologists, we're always concerned, are we going to cause more toxicity by giving radiation if there's potentially scarring there? So we'd elected to treat him on the MRI linac. He also had hydrogel put in, which was worked out very well for him because it moved that rectum out of the way. And what we were able to do every day was to outline where the urethra was at each one of his treatments, and then ensure that our radiation doses were lower to the urethra to ensure that he wasn't going to get any major long-term urinary side effects or toxicity. And again, throughout his whole treatment, he reported no urinary or bowel symptoms for his treatment. The fourth case is a gentleman who was planned for a stereotactic treatment, 5 treatments on a standard linear accelerator. And in those situations, to treat on a standard linear accelerator or linac, they would require fiducials and hydrogel put in. This gentleman had their fiducial hydrogels placed at another center, and unfortunately the seeds of the fiducials were in an area which was not usable, and the hydrogel again was not in a suitable position. And I used the bottom picture for a comparison. This was a gentleman that had hydrogel placed on the left here. You can see the rectum in red, the prostate in red, the rectum at the back here, and that white area is the hydrogel. So it is with the prostate out beautifully, and that was done by Stricker. This specific patient who was sent to us for treatment, unfortunately, you can see the hydrogel was not placed in a position which moved the prostate out of the area at all. However, he was still able to be treated with us with 5 treatments, and again, he reported no urinary or bowel side effect. Developments that we're looking to do at the St. Vincent's area is a virtual brachytherapy. As we said, we know that high dose of radiation improve outcomes in prostate cancer. So we'll be looking at developing a program where we're delivering these higher doses of radiation, in a sense, doing what the high dose brachytherapy was doing, but non-invasively using the MRI LINAC. This is feeding off from a previous study, an Australian study, which done this in standard LINAC, but we're excited to get that off the ground, hopefully very soon. With regards after prostate radiotherapy, the question always comes, how do you know whether it's worked? I tell patients it can take 12 to 18 months afterwards, and these are patients who are not on any androgen deprivation therapy. What we know with standard treatments, even 20 treatments, that the PSA will go down slowly over that time. With stereotactic treatment, it tends to come down a lot quicker. What we're looking for is that PSA to hit a nadir, which is essentially the lowest level it will hit, and we're looking at the trend. If it maintains at that area, then we're happy that the radiotherapy has done its job. With regards to how do we know that the radiotherapy has not, obviously if the PSA doesn't come down at all, it has not done its job, or there was evidence of disease outside of the pelvic area. But other factors we would look at to define a failure of the radiotherapy would be either 3 consecutive rises in the PSA after they've hit the nadir, or the nadir plus 2. So if their nadir was 1, if they ever got to 3, by definition they have failed, but they would have likely had 3 consecutive rises before they got to that. Another question I commonly get asked is erectile function after radiotherapy. There's a lot of evidence coming out now, and it's something that we are looking to do is what we call vessel-sparing radiotherapy. This was a study published a while ago. This was done on a standard machine, 135 patients aged about 60. And what they found at 2 years, of the men that had erectile function to begin with, 87% of them maintained erectile function at 2 years. After being treated with this technique. And essentially what this technique involves is when we give our radiation, we give extra time to define the structures which are important for erectile function, and we put hard limits of the radiation that can be delivered to them. And that's how we found that 88% of the men were sexually active at 5 years. These are the sort of things that something like an MRI LINAC really lends itself great to, as we can ensure that we avoid these structures daily and make sure that any changes are accounted for. In terms of the outcomes in these patients from a prostate standpoint, these patients in this study at least their prostate cancer outcomes were similar to published outcomes. So there was no, they did not receive inferior treatment because there was a desire to come off those the vessels or the nerves required for erectile function. However, this can't be done for everyone, and as Professor Strick outlined with regards to surgery, same with radiation. If the tumour is very close to these, it may be difficult to spare these vessels. Knowing that my time's very short, I just want to quickly state that radiotherapy after prostatectomy is something which is commonly done as well. Recent evidence has come out to show that the role of radiotherapy, especially in these low to intermediate risk cases after prostatectomy. Previously, there used to be a push to give radiation pretty quickly afterwards. However, we now know that there's no advantage to that, and that actually we should take a watching approach and only give radiation when certain things are met. current indications would be that after their prostatectomy, their PSA would go less than 0.1. And the only indications to consider radiotherapy would be if they had 2 consecutive rises in their PSA and that the final value was greater than 0.1, or they had 3 consecutive rises. We also, however, if their PSA after their prostatectomy was greater than 0.1, it doesn't mean that they need radiotherapy, but it should just be a discussion. Probably can be with the urologist about what sort of follow-up they would want after that to maintain, to ensure if anything is going on. With a very high risk group or the high risk group, again, unfortunately, there is limited high-level data about when's the optimal time to give radiation in this cohort of patients. So I would say it just needs a discussion again with urologists or the radiation oncologist. The question again I always get asked is, what do I treat after a prostatectomy? There are published guidelines, and Australian guidelines published by Sidham, Kneebone, and the group define this area. Essentially, it's an area which is bounded by the bladder and the rectum. Some situations, there's also a need to treat the pelvis because of the potential for lymph node spread. But in treating this area, this prostate bed area, we can see it's an area defined by highly movable organ, which will move. We know it moves, and a lot of evidence has shown it to move, and the way we account for that is to give big margin of errors on them. However, we have started treating these on our MRI LINAC again, knowing that they move. It sets itself up nicely to be treated with this advanced technology, because we can account for that every time they come in. So my take-home messages would essentially be radiotherapy and surgery are both curative options for prostate cancer, with high-level evidence shows equivalence, especially in that low to intermediate risk. It's important that they ensure that they have a discussion and well informed about all the options available. In terms of radiotherapy, again, treatment can be anywhere from 5 to 39, even up to 40 treatments, especially in these low to intermediate risk patients. There is a move, if possible, to treat these people with 5 treatments to get the treatment done for them. With advanced techniques, the radiotherapy is very well tolerated. And also with advanced technology such as the MRI LINAC, we feel we can offer a better treatment to these patients with lower chances of toxicity. Thank you for your time.
Great, thank you. Just a couple of questions. So the risk for secondary cancers after prostate radiotherapy,
yep.
What are those numbers like?
Yeah, that's an excellent question. In terms of the published data, the risk of having a second cancer after any sort of radiotherapy in general is quoted in the order of about, most people quote 1 in 1,000, but the highest it's ever been quoted is about 1 in 400. A lot of this data is derived, unfortunately, when children have had radiotherapy. Their risk of developing a second malignancy. In terms of the timing of that second malignancy, it would not happen straight away. It does take a number of years if it was to happen, anywhere from 10 to 20 all the way up to 30 to 40 years. So it is a very late potential side effect.
Okay, another question. For patients without private insurance, can his prostate cancer be treated by the MR LINAC?
So unfortunately, private insurance doesn't cover any radiotherapy done at a private center. In terms of the cost, majority of the cost is still covered by Medicare. And in terms of the out-of-pocket costs, it depends on a number of things in terms of how much treatment they're getting, where they are up to into their safety net. But there is a small out-of-pocket cost for the MRI.
Okay, a question about the PSA. So when should you repeat a PSA again if it is below the age-related median during screening?
I'm not sure if Professor Stricker wanted to answer that one.
Yeah, can you hear me?
Yes.
We can, yes.
So I think there's 2 scenarios. Scenario 1 is where you've got a good reason that the PSA was elevated, and that scenario might be recent ejaculation, a recent episode of some prostatitis-like symptoms, And in that scenario, or a very long bike ride, I tend to repeat it again at the earliest convenience when you're sure that you don't have any issues. And those issues might be, it might be just abstaining from ejaculation, waiting for the urinary symptoms to settle. On the other hand, if they're doing it all correctly and it's elevated and it's above the age-specific reference range, then in that situation, I tend to wait 3 months and then repeat it just to see if it's really elevated, because the Medicare item number for covering MRI means that you have to have it done, a repeat PSA elevated within 3 months of the other PSA to be covered by the Medicare rebate. So that's why I tend to do it within 3 months.
Okay, great. And a low-risk patient post-treatment, how often does he need a PSA test?
Is this a question after surgery or radiotherapy or either?
It just says post-treatment.
So post-radiotherapy, I would do a PSA. I would wait for at least 6 weeks to up to 3 months to do another PSA. With surgery, Professor Stricker, would you like to comment?
So post-surgery, we tend to wait 6 weeks and then do the first PSA. And after surgery, that should essentially be less than 0.05, preferably less than 0.01.
Right, thank you. That seems to be the last question. If anybody does have any other questions, please submit them now. Okay, I think that might be the end of it. So thank you very much, Professor Stricker and Dr. De Leon, for presenting tonight. Great presentations tonight. And thank you everybody